I'm going to now just briefly introduce the panelists who will be talking with me today on particularly emphasizing the questions on screening for alpha-1 antitrypsin deficiency. So three very engaged young folks who will be participating today. The first, Monica Goldklang, is from Columbia University in New York, and she's a very active investigator in alpha-1 as well as a practitioner. Secondly, we have Igor from UCLA, who's engaged not only in alpha-1 education, but also is an intensivist and an expert in liver disease and the liver component of alpha-1 antitrypsin. And lastly, Kyle Hogarth, who is a pulmonologist, critical care specialist from the University of Chicago, where he also is very well known for his interest in alpha-1 antitrypsin and his ability to educate healthcare practitioners on this subject. The first question we're going to have today is a really important one, and I have worked many years with rare lung diseases, and it really comes down to the medical community knowing about alpha-1 antitrypsin deficiency since Dr. Erickson and his colleagues described it more than 50 years ago. Yet it is estimated that approximately 90% of people with this genetic condition remained undiagnosed. Why do you think that is, Kyle? What is your feeling about that problem that remains a big issue?
Jim, thanks for having me. And you're right. It's an ongoing problem. And as I always tell people, it's just rarely tested for. And the problem with alpha-1 is because it principally causes emphysema and COPD and chronic obstructed airways diseases. We see those day in and day out. And so I've often said alpha is sort of lost in the noise of all of the obstructed diseases that all of us deal with. And so you referenced obviously the original discovery of alpha-1, and that would probably represent the lowest hanging fruit. And what I mean by that is, do you really think we needed all this medical education to recognize a 40-year-old end-stage emphysema patient and a barely smoker? That doesn't make any sense. Right. You know something's weird, right? And so that's fine, but as we all know, alpha-1 has a wide variety of presentations. And so getting away from the clinical diagnosis of alpha-1, because there is no way to clinically diagnose this, to what it really is, which is a laboratory diagnosis, and the recognition that the suspicion for the disease comes with the diagnosis of an obstructed lung disorder, and shifting your brain from ruling it in to ruling it out. You know, and I always use the analogy, I've ordered a lot of CT scans to rule out PE, right, and it's a big number, and there's about this many PEs I have found.
That's right.
And, yeah, you know, I haven't stopped ordering it when I'm suspicious of it. Well, if I'm passing out an inhaler for the diagnosis of COPD, then I'm going to test you for alpha-1. And, you know, look, I want it to be negative, right? That's the other mindset we have. I don't want anyone to have this horrible disease. And so I'm really glad when it comes back negative. We're going to see this disease continue on if we don't keep looking for it and being able to manage it. So I got a little long-winded, so I'll shut up, but thanks.
Yeah, that's really some very, very good insight. Monica, I'd love to hear your thoughts on that question also, on why this orphan disease, because there's less than 200,000, and as Kyle pointed out, we've been hearing about it for a good while, but why do you think people are not being diagnosed? And that's still a problem, I think, even to this day. So what is your insight on that, Monica?
You know, for me, I think that I agree with everything that Dr. Hogarth said. I do believe that this is something that there are certain people that it's very obvious, but part of it is about the medical education that we all receive. And there's so much to think about in the differential diagnosis of this disease or that disease. And if you start thinking about zebras very early in your training, you know, you can become overwhelmed. And so I think that, you know, we've all been taught to kind of really not think about these zebras, but in fact, it is a laboratory diagnosis, and it's something that we all need to be thinking about. But I think that people believe through our medical training that we know it when we see it. But as somebody who practices in New York City where there's a lot of population mixing and a lot of people of different ethnicities, I still diagnose ZZ Alpha-1 patients. And so it isn't just the patient that you can see it and that they're of Irish descent. We need to look at it in all of our patients. And getting past that is something about us also as a community, educating practitioners to understand there are treatments for it. Because I often hear people say, well, why would you test for it? It's a genetic disease. And so that's on us as a community to really educate.
Well, thank you both. I'm going to move on now to another very interesting question. And that is, what motivated you to become an Alpha-1 advocate and support systematic screening, which is what we're going to be talking for Alpha-1 antitrypsin deficiency? And I'd like to first pose the question to Dr. Igor. Can you, how did you start out there in UCLA on the West Coast?
Sure. Well, first, thanks, Jim, and thanks for having me in this great crowd. I actually didn't start with Alpha-1 on the West Coast. I started on the East Coast in New York. But that said, I'm a pulmonologist and interested in COPD, and this is actually the only genetic and very well described genetic cause for familiar cause of COPD. But that said, I think the significance of this disorder goes much beyond the pulmonary medicine. It's a predisposition, and it's a predisposition to a whole set of various diseases that affect respiratory tract or GI tract or skin, etc. So with that said, as a genetic disorder, actually, this is, in my mind, a fairly low-hanging fruit for any practitioner. This is a genetic disorder that has a very well described genotype and its relationship with the endotype and phenotype. It is a genetic disorder that actually is very simple and very cheap and easy to test. And then the results that if you don't rule out, as Kyle pointed out, but actually if unfortunately you rule in, this is the piece of information that any physician, not pulmonologist, actually delivers, and it's very significant and has amazing impact on the life of a person, independent on whether that person is sick and has significant lung disease, because you're providing an explanation. This also actually significantly impacts the life of someone who does not have any evidence of disease, of lung disease or gastrointestinal, because lifestyle modification may make a major impact on the whole lifetime of that patient. And then in addition, you do have impact on the family members and the relatives of a person who gets tested. So I think that pretty much the bang that you get for a buck actually is such significant that I think that anyone who tests contributes a lot.